All right, so we're going to start again. Uh, Dr. Fisher, Dr. Kristen Fisher from Houston is going to talk on the treatments for NORSE fires. And for those in the audience, I can introduce Dr. Fisher as well as one of the people that has been instrumental in the treatment of NORSE fires with intrathecal dexamethasone. So welcome, Kristen.
Thanks. Is my screen sharing okay, Dr. Aviello?
Yes.
Okay, wonderful. I have a handful of slides, and my disclosure is I'm not going to talk about every single thing on all the slides, but I know since this is being recorded that people can go back and look at things later. So I'm going to try to just touch on the most important things that I think I wanted to cover. First of all, I would say I'm going to focus on just the acute treatment of NORSE fires, and starting with going over the treatment goals. And so really kind of the first thing in our treatment goal of acute NORSE fires is that treatment of the initial onset of status epilepticus. So we want to stop the refractory status, and then in addition to that, maintain adequate seizure control with recurrence of status epilepticus, and then do our best to minimize the complications that occur related to prolonged seizures and status epilepticus. And then in addition to that, our treatment is also then focused on not just treating the status epilepticus itself, but the underlying cause of the presentation, whether that be infectious, autoimmune, or other innate immune dysfunction, and then the initiation of an early immunotherapy. So first, to touch on the anti-seizure medications, just in general for status epilepticus, our initial management of anyone that comes in with a prolonged seizure is with a benzodiazepine medication. So that's whether that be Ativan, diazepam, that class of medication. And if a patient has ongoing seizures despite an appropriately dosed medication of a benzodiazepine, then our recommendations is for administration of a second-line anti-seizure medication, which oftentimes you'll hear us as neurologists saying a loading dose of a medication. If the patient then has ongoing seizure activity despite the use of an adequately dosed benzodiazepine in addition to the second-line medication, that is when a patient develops what is labeled as refractory status epilepticus. So this is our category of patients where we should start be thinking about NORSE fires. And this is when a patient is given a third-line anti-seizure medication, and then the consideration of use of an anesthetic infusion is used, such as midazolam, pentobarbital, and other medications in that category. So really the primary goal for the anti-seizure management in patients with NORSE fires is to maintain the like maintain no return of status epilepticus, but also be able to reduce or remove the anesthetic infusions. We do this by using not just bolus medications, but regular maintenance medications. We try to use medications that have multiple mechanism of action. So that way we're kind of using different classes of medications to control the seizures in different ways. There is some data on using very high dose phenobarbital, so I'm sure those family members are very familiar with us using high-dose phenobarbital. Is shown to be very beneficial in refractory status epilepticus. But really, there's no specific anti-seizure medication in particular that's geared just for NORSE fires at this point in time. These patients are just placed on numerous anti-seizure medications, and then not just one, sometimes multiple anesthetic infusions for seizure control. Other treatments that we use for anti-seizure management is the ketogenic diet. There's been increase in use in patients with refractory status epilepticus and really should be considered in all patients with NORSE fires. So it's recommended, or if you have a suspicion early in a presentation, for starting that initiation of the laboratory evaluation and initiation of the ketogenic diet. It's been shown to help in aiding in seizure reduction in seizure burden and reduction in anesthetic infusion requirements. And the reason why this work is potentially just multifactorial. It has some multiple effects on neurotransmitter balance, ion channel regulation, mitochondrial function, and also inflammation. So it's definitely something that should be considered in patients with NORSE fires. There's also patients that are placed on Epidiolex. The data in this is much more limited, and maybe it's more beneficial in the chronic phase of refractory epilepsy. So I will not go too much into detail of that, but it is something that's utilized in the acute phase as well. It has some anti-inflammatory effects, and it's helpful in the phase of neuronal excitability. And then getting into immunotherapy medications, I think an important thing is that to review kind of why do we use immunotherapy in NORSE fires, because maybe this isn't always kind of explained in the best detail. There's just a lot more evidence now that's shown that there is evidence of immune dysregulation and neuroinflammation in patients with NORSE fires, whether it be in blood, spinal fluid, and we can see that there's this activation of the innate immune system, which is our body's like first line defense that we are born with, that is there to help prevent from viruses and other infections, but for some reason it gets dysregulated, activated, causing inflammation throughout the body and the brain. This neuroinflammation, that the inflammation around the brain that occurs actually can lead to the initiation of seizures. So the inflammation is irritating around the brain. So it can cause seizure to happen, but then it can also further propagate seizures. So the inflammation happens and then can cause more and more and more seizures to occur if we don't get it under control. So for this reason, this is why immunotherapy has become to be a key component in the use of treatment of NORSE fires. Overall, kind of our current consensus recommendations for immunotherapy is generally a stepwise approach. So you want to be thinking this is where early recognition is very important, because then we really want to start initiation of first line immunotherapy, which is IV steroids and IVIG, really within the first 48 hours of the onset of status epilepticus. If a patient has certain clinical features that may make us suspicious for an autoimmune encephalitis or an antibody-mediated disorder, sometimes patients also get plasmapheresis early in the course as first-line therapy, but this is less common in those with cryptogenic NORSE fires. And then it's recommended that patients get started on what we consider to be our second-line immunotherapy within 7 days of presentations if our first-line treatments are ineffective. So a patient has ongoing need for anesthetic infusions, recurrence of status epilepticus or ongoing status epilepticus, we really want to initiate this immunotherapy treatment within the first 7 days of onset of status epilepticus. And again, if a patient is suspected to have an antibody-mediated disorder, then we actually use rituximab. Anakinra and tocilizumab are the two most common used medications and what's in our current consensus guidelines. I've listed these medications here, but and the differences between the two. But essentially, both medications act on parts of the innate immune system that are pro-inflammatory, so cause inflammation to occur in the body. And so these medications are goal to help stop these parts of the innate immune system, help kind of mitigate that inflammatory response that's going on. Interestingly, too, both of these cytokines, the IL-1 and IL-6, are cytokines that have been shown to have some pro-epileptogenic effects. So they actually might perpetuate seizures. So reasons why we believe these medications might additionally be helpful. Both of these medications have their hosts of side effects and potential risks with them as well. And so it's possible that we might choose one of these medications over another based on, what the patient's current status is.
So 2 minutes.
But right now, there's really no head-to-head comparison on these medications and no indications as which one to use first, and no indications when to switch from one to another if you felt one to be ineffective. But there is the upcoming Combat NORSE trial that will hopefully give us some more answers. Additionally, there's some more current use, and as Dr. Riviello mentioned, more use of intrathecal dexamethasone, which is not currently part of consensus recommendations, but has definitely been increasingly used, and a lot of discussion about the early use of intrathecal dexamethasone in combination with our other second-line therapies, such as anakinra and tocilizumab. And then another medication that's been mentioned more frequently, but there's very few case reports out right now, is medication called JAK inhibitors. That is another part of the innate immune system pathway that's used in other rheumatologic or hyperinflammatory disorders, but has been shown to maybe have some benefit, and it should be of consideration in patients that are refractory to other treatments. So overall, just in summary, I would say that an important aspect is that multimodal therapy is really a key part of the treatment of NORSE fires. So that's not just the anti-seizure medications, but also ketogenic diet and immunotherapy treatment. And the goal really is for termination of status epilepticus and prevent recurrence. We really need to improve early recognition and consideration for NORSE fires. That helps our treatment pathways and decision-making towards treatments. And there are still significant gaps in our understanding of certain aspects of the treatment, with that being which second-line immunotherapies should we be using? Are we using early intrathecal treatments? Should we be doing combination treatments and other things like that? When should we consider transitioning immunotherapies from one to another if one does not have a perceived benefit? And when should we consider de-escalation of immunotherapy or duration of immunotherapy use in the acute phase?
All right. Well, thank you very much for that concise talk. And now to the family panel.
Oh, wait, Jim, we have two questions
Oh, yes.
in the chat.
Oh, for Kristen. So,
Yes.
any data on the efficacy of cenobamate in NORSE fires?
I'll
I'm
give
not
my
aware
my
that there is any
disclosure that I'm not an
specific.
epileptologist, but I don't know that there's any any existing current published efficacy on the use of cenobamate, but I know that anecdotally people have found that it'd be a very beneficial medication. I have multiple patients of my own that are on cenobamate and done well with that medication. And so, a lot of time we bring it up in the topic of acute treatment, yes.
And another question on any concerns of safety or of of the IT decks.
No, I will say that there's been a number of case reports and case series that have been published to date, and I will say that of all the data that we have seen, that there have been not any complications, adverse effects with that medication. It's shown to be very safe. There has been intrathecal treatments used and intrathecal steroids used in other inflammatory disorders that have similar data as well, showing that it's a very safe treatment overall.
All right, thank you. There's one other question, but we'll deal with that after we hear the family's perspective on the treatments.
Jim, Desiree has her hand
Oh,
raised.
hello.
Hi. So as far as treatment options and communication of treatment options, I think that communication should go both ways. One lesson our family has learned the hard way is that chronic fires cannot always be approached as routine epilepsy. Repeatedly, medications described as clean, well tolerated, or low risk have produced severe and unexpected psychiatric reactions for our son. Families understand that there's no standard treatment for chronic NORSE or fires yet. What we need clinicians to understand is that there may not be a standard response either. In our son's case, the only immunotherapy he received was IVIG during the acute phase nearly 10 years ago. Since then, we've watched new immunotherapies emerge, but many families are navigating treatments where the long-term effects and outcomes in chronic NORSE and fires are still not fully understood. So when we tell you what our child's reaction to a drug has been, whether it's an ASM or immunotherapy, listen, treat what we have to say as data that, yes, may not fit every NORSE and fires patient, but fits the patient in front of you. We've become experts at the way our loved ones present with chronic NORSE and fires. So if more doctors took the time to listen to our observations, rather than judging them against every commonly listed side effect or routine epilepsy, I think we might be much further along in research and treatment options. If we're ever going to come close to standardizing longitudinal care for NORSE and fires, the data has to come from somewhere, and the caregivers are the ones holding most of their loved ones' long-term data. The bottom line is that collaboration and partnership with patients and caregivers is essential for any treatment plan.
Okay, thank you very much. I think Shabana had her hand up next.
Yes, I just wanted to share two things from Layla's treatment. One was that I completely taken just what Desiree has just said, that caregivers are very observant because we are there 24/7 hours with Layla in intensive care. Layla had NORSE in September 2025. And then after that, I learned there was another girl a bit older than Layla, age 21. And the difference was that girl received tocilizumab day 7 of when they were diagnosed NORSE. Basically, the intensivist in her case suspected and had the tocilizumab ready for her day 7. In comparison, Layla received it day 21. And we thought although they both had anakinra before, but as soon as Layla received tocilizumab, there was a difference. They couldn't give her the second dose 2 weeks later because Layla had other complications of intensive care, like she went into septicemia and they couldn't give her that. But receiving the dose at different timings, and whether there is a consensus that how early the two girls, the difference in the timeline would have made a difference, because one woke up after 17 days versus Layla after 2 months, and both made their physical recovery. Layla was completely at a different level of recovery where she had to go through everything all over again, where the other girl made a very quick recovery. So that was one comment. While we waited for the global consensus to come up with a strategy for Layla, intrathecal dex, we also thought that when Layla was hampered, she couldn't take any more immunotherapy. Then came the intrathecal dex, and her EEGs. I learned how to actually read an EEG just by looking at the tracings 24/7. They dramatically improved once she received her first dose, and then there were 2 further doses planned. And whereas we were having mixed consensus about, is it dangerous, is it safe and everything, but that's the one treatment that turned a corner in Layla's recovery and prolonged coma. And I think that was one of the reasons in the end they were able to start waking her up. And that's when they were withdrawing treatment, she didn't go into status. So I just wanted to share that, although I'm still trying to understand all the different therapies and the timelines. But is there, and my question to everybody, or the researchers or the clinicians in the room, that is there an agreed timeline, how early, when you suspect there is NORSE fires, that immunotherapy should be initiated? I know there is no one better than the other, but what about the place for intrathecal dex? How soon that should be introduced?
And I believe that, Deborah, were you next? You had your hand up? Oh, okay. Massimiliano.
Yes, I just want to describe a little bit what seems to have worked for my son. So, first of all, in the acute phase, when he was in the ICU, he got several of the treatments that you have discussed so far. I would just mention that in his case, the administration of anakinra was started very soon. And this is the first point, even though at that time no cytokines were tested. So doctor just followed the standards guidelines for the management of the fires in the acute phase. But what the doctor thinks to have worked in his case was starting the administration of highly purified cannabidiol. So the Epidiolex is the commercial name. So after 6-7 days starting administrating CBD, basically the seizure stopped. So regarding the chronic phase, personally, we have seen that we got a good improvement in the seizure frequency when we started administrating clobazam together with the Epidiolex, because Epidiolex is like a booster for the clobazam. And now, in parallel to the classical management through the administration of the anti-seizure medication, we are starting a new approach. It is called the microbiome-related approach. And the objective is to perform some tests we already did, and to define what could be nutritional intervention designed to increase the short chain fatty acid production, which may have a neuroprotective and anti-inflammatory effect, and define what could be personalized probiotics or prebiotics to promote, again, anti-inflammatory bacterial population. This approach could potentially support long-term management of fires by aiming to reduce persistent neuroinflammation, improve seizure control, and relieve the current dosage of the anti-seizure medications. Thank you.
Thank you very much. I would say that cannabidiol also has some anti-inflammatory autoimmune properties to it. It works through the mTOR system, so it may work through multiple receptor areas. And I would ask Dr. Fisher for her opinion on the rapidity which we would give dexamethasone. We are trying here to have our patients on anakinra by day 4 or 5 if we have not seen an improvement with our IVIG and our corticosteroids, but they are started more while we're working someone up for an autoimmune encephalitis rather than directly for NORSE fires. So if we don't see an improvement by then, we're typically starting anakinra. So Dr. Fisher?
Yes, yes. And I would say that more as we've used the intrathecal dexamethasone more frequently now, we've seen that because of its safety profile and maybe that it may potentially has some combination effect, that in combination with the systemic immune therapies, maybe there's a synergistic benefit to those medications because we're targeting the systemic immune system in addition to local immune therapy directly into the CNS, that it potentially provides more benefit. And because it is a low risk overall treatment that we've seen and seen it safe in combination, we're starting to use the intrathecal dex more early on. So if we're starting someone on anakinra in that first 7 days or tocilizumab, that we're using the intrathecal dexamethasone in combination with that. And we're dosing every 3 to 4 days, just depending on the patient's stability and the ability to do it, just because it requires a lot of coordination and doing it in the ICU setting. And if there's other things going on, that sometimes it's hard to do more frequently, but that's kind of what our schedule and timeline has been. And we usually do it, until 6 doses. We've done 7 doses in patients. There's not an exact number to that we know of at this point, just because still it is limited on terms of what has been done. But if a patient, comes off anesthetic infusions prior to that time point, then we don't do any further doses unless something were to change that.
All right, thank you very much. I think we'll move on to the clinician family communication. And this is going to start with Dr. Mark Wainwright from University of Washington in Seattle. And Dr. Wainwright is, clearly one of the leaders, if not one of the founders of pediatric neurocritical care. So Dr. Wainwright, thank you for speaking for us.
My pleasure. Thank you for the invitation. Can you see my slides okay?
Not yet. Yes, now.
Got them now? Okay. So I just have a couple of slides.
But they're not in presentation mode, just for...
Okay. How's that?
Yes.
Perfect. Okay. I'm going to focus on the phases of NORSE fires from the perspective of communication in the family, not in terms of the biology of the disease. I'll talk a little bit about the way my experience of working with parents. I'm a pediatric neurologist, and those are my colleagues as well. Through the initial presentation, the first day or two of presentation, then the ICU course, the transition to inpatient floor and rehab, and then the transition to going home and that long-term recovery. And this is from the lived experience, not the phase of the biology of the disease. This within the many things that can go well or badly within communication for a family member with this suspected or confirmed diagnosis. They exemplify many of the challenges of caring for patients in the ICU, and I'll talk about that in a moment. So typically, this is a healthy person, a healthy child, presents with an acute illness requiring an ICU admission, already enormously stressful for any family. That's combined with the emerging uncertain diagnosis. Typically, for parents attending this meeting, you probably recall being presented with some clinician describing the wide variety of genetic, rheumatologic, infectious, inflammatory, metabolic causes that might cause this particular presentation. So you have uncertain diagnosis, uncertain mechanism combined with empiric therapy. Superimposed on that is that requires multiple teams to be involved in the ICU care, which already has many different nurses and clinicians. So you may be exposed to people from rheumatology, genetics, biochemical genetics and metabolism, neurology, neurocritical care, and epilepsy. So superimposed on the need for empiric treatment, an uncertain diagnosis, a shift from a healthy person to someone being critically ill over the space of hours or a day or so, is a need to develop trust in the treatment team. And for children, certainly, these patients may require transport to an academic center with expertise in the management of refractory or super refractory status epilepticus. So you're removed from your social networks and family networks with people who you don't yet know who to trust, who are trying to explain a rare and uncertain diagnosis. This is enormously stressful. There are many different things that can go wrong with miscommunication, even with experienced and well-intentioned teams. So a key theme of this is really the need to establish trust, to recognize the enormous stress families are under, the lack of resources they have, and this exemplifies the need for continuity of communication and humility of that communication, because there's an enormous amount about with this disease we don't know. As we start to focus then in the ICU on treatment, the early phases of treatment target seizures and the complications of treating those seizures, the hypotension, the risk for infections, renal, liver dysfunction, and so on. But the targets of that treatment are very different from the long-term targets, which are critical. Obviously, they include prevention of epilepsy, if at all possible. But what emerges then over the next weeks within the ICU is a gradual shift to recognizing that the many other targets you as parents and family members already know about, the behavioral and cognitive issues and the access to care for those issues. So what happens in the ICU course is another theme that's important here in communication, is some patient careful and well-timed anticipatory guidance. That is preparing people. Successful treatment of the status epilepticus, the transition to extubation, the management with a combination of anti-seizure medications is only part of what a family needs to expect. The other things that are emerging, the behavioral and the cognitive, the sleep issues, the reintegration to the family and school, those are all critical aspects of the long-term recovery as well, and they need to be discussed and brought up when the time is right. So this is another aspect of the continuity of communication and provision of that communication by a person or people who are experienced with this disorder and can judge when the families are ready to hear it. And that's the other aspect of this. Families shift from hearing about this rare, complex disorder to becoming experts in it. They do that by informing themselves and by talking to other families as well. So gradually you see a mismatch between the expertise of the team taking care of the patient and what the family understands about that disorder. And because the teams turn over every week, again, you need somebody that we as physicians or clinicians need to be able to provide that continuity of communication, that someone is humble about their expertise and is able to target what they're explaining to a family with the appropriate anticipatory guidance at the right time. And part of that is shifting the definition of what is recovery and improvement. You move from stopping seizures to doing all the other things I talked about as well. And that anticipation of what to expect is really important. The transition from the ICU to the floor or rehab unit is difficult. it's helpful to have the rehab team come and meet the families. The family go and see what the rehab unit is look like. Helping people understand what's coming so they're not surprised is really important, and that includes a focus on going home too. The transition from those early few days where you're focusing on the need for intubation, the management of all these anesthetics, the success of extubation, starting anti-seizure medications, to the hard yards of reintegrating into the home and school and recognizing the needs of your family member, who's a different person in some ways when they go home, and providing that access is really important. And someone needs to explain that really carefully and kindly. So there are many things that can go wrong here, despite everyone's best efforts. It's a rare disease, unclear mechanism, a long hospital stay, a very long recovery, and the shift in the goals of care from stopping the seizures to really providing the appropriate behavioral and cognitive support. Parents become experts in this disorder, and the way things are communicated needs to understand the parents' expertise as well. They know their child, but they've also become really expert in understanding NORSE and fires too. So everybody needs to be humble. Any clinician or well-meaning parent of another child who claims to know the perfect treatment for your child, they're probably wrong. No one knows exactly what to do here. You have to be thoughtful about this. People need to be prepared for a very long recovery. And what parents often don't hear is how the family environment matters, how important their care is. That's therapy as well. This isn't just a platitude to make people feel better. There are data for this. There's a science behind it, mostly from the congenital heart disease population. Parents are a key part of the recovery process. That's therapy. Most recovery takes place outside the ICU and the rehab unit once people go home, and that stable and stimulating home environment is a critical part of long-term recovery as well. That's everything I had to say. Thank you.
All right, Mark, thank you very much. We are going to move on to the panel discussion. And is Wajahat Ali speaking first?
Sorry, can you hear me?
Yes, now we can.
Yes, hi, sorry. I'm Layla's dad and Shabana's husband who has spoken earlier on. I just had a very quick point to mention here related to the communications. And primarily, it's just, I wanted to keep it very short, but just mention that miscommunications or not understanding the parents, the communications between the clinicians and the rest of the teams and parents can at times be very, very pressurizing. While the parents, they are going through enormous stress, and at times they might sound a bit over the top, but at no points parents should or the families should actually undermine the expertise or the hard work of the clinicians and the teams. But at the same time, the teams, they have to understand that the parents, as long as they have been polite and courteous and not disrespectful, they are there to fight the case of their loved ones. They should not be misunderstood. They should not be considered as people who are trying to overpressurize or push the clinicians and the teams beyond their means. And quite recently, what our experience had been in two different places. One, with as Shabana mentioned, the teams at Layla's hospital, they came together in the form of MDTs, and they were like very, very helpful, and they understood that the families are actually the eyes and ears of the teams. And they supported us, they valued our input and everything. Whereas our next experience was completely the opposite, where the parents' opinions, they were treated as over pressurizing the teams, and they were being generally discarded. So I'm not undermining anybody. I'm just trying to highlight the importance of how valuable the communication, the health of communication between the teams and the parents or the loved ones or the families who are involved, how important it is and how it should not be undervalued. Thank you.
Thank you very much. I think that is important that we use the families as our eyes and ears for the reporting what's going on with the patients. Let's see who's next. I don't see other hands. Who is speaking next? Oh, Desiree, go ahead.
Hi. So when David was in a coma, we had one specialist that was called in to assess David. And as far as communication goes, he didn't want to take the time to explain what was going on. I quickly explained to the doctor that my husband had medical training and that he'd understand. And he then quickly apologized and then proceeded to tell my husband and I what was going on. In that case, the doctor was only willing to explain the situation if he didn't have to dumb down his explanation. Thankfully, my husband had medical training, but the doctor's unwillingness to explain what was going on in layman's terms at such a critical time was unacceptable. Families have a right to know what's going on in their loved one's care, and it was the doctor's responsibility to communicate with families in a comprehensible way about the care, our son was receiving. Also, just a point I think is so important. Many of you work in teaching hospitals. You're teaching interns and residents every day because they'll one day be fully responsible for caring for patients. When you round on NORSE and FIRES patients, remember that many of those parents may become the sole long-term caregivers after discharge. So teach them too. Their loved ones' lives may depend on what they learn in the hospital, and they aren't learning to become your competition. They need to understand what changes should concern them and how to communicate those observations effectively. Families often, they spend years observing their loved ones, so help them learn to translate those observations into meaningful clinical language so they can become effective partners in care. Those families will become collaborators and a valuable part of the team. So take them under your wings and teach them.
Thank you, Shabana.
Just to add to what Desiree is saying, that communication, and I like the way Mark went through different phrases of the illness, NORSE and FIRES. And I want to highlight two communication that one was when Layla was on the ward, neurology ward, stepped down from ICE intensive care. The communication, especially nursing staff, they were not great at. Whereas the MDTs were happening in an intensive care, once we were on the ward, we realized that despite being on a neurology ward, a lot of the nursing staff did not have a neurology training, and hence they would perceive Layla as being any other patient and not realize that she doesn't have memory, she doesn't realize what's going on, because on the surface, the patient would look normal. So that is something that training, staff training, medical training, whereas we have to improve awareness of the illness, it also comes with the caveat of improved training of professionals too, because there is a big gap. If you don't know about NORSE and FIRES, how are you going to care about it? That's one thing. And as Layla went through different phases of her recovery, and now she's in rehab, and we are looking at discharge in about 3 to 4 weeks. In this journey, and initially when I was saying, don't just see NORSE, see the patient too. Start communicating with the patient. Now that she is cognitively so much better, what happens is that when the ward rounds, they are 15 minutes, you have 15 minutes, we have other patients, there are other complex patients too. That's what we've been hearing in rehab, which is quite unpleasant. Layla's been in hospital for 10 months, and by the time she goes home, it'll be 11 months. It is not a nice thing to hear that you time constraints. Yes, I know there are many complex patients, not just Norse, but I think there must be a better way where clinicians and other people can convey that time constraint message. But don't forget the patient. That still she looks at us, we do communicate, but she would like to hear from her attending doctor. Her attending the therapists are much better, but I think it's in rehabilitation our experience has not been great, and I think it's not the experience, it's also the communication has not been great. So don't forget the patient, do talk to the patient as well, is what my message would be.
Thank you. Massimiliano? Oh, he took his hand down. So then,
No, you have to.
Sorry, I was muted. Sorry.
oh, okay.
In our case, during the acute phase, what we valued most was having regular meetings with the medical team. During these updates, the doctors were very clear about the aspect of the disease, from potential outcomes to the purpose of the ongoing medications and therapies. But in the chronic phase, the paradigm shifts. So the contact with the medical team becomes much less frequent, and we, as caregivers and family, become the primary source of information for the patient's daily lives, as previously underlined by Desiree. So, as caregivers, we are the ones who track and report clinical evidences, the frequency of the seizures, the effectiveness of the anti-seizure medications, the side effects, and also the behavioral changes. For these reasons, building a strong partnership of trust between physicians and caregivers is absolutely essential. But this trust is not given. It must be built over time. To foster this trust, doctors need to create a welcoming space where families feel free to share their observations, concerns, and also ideas sometimes. At the same time, we as caregivers must be as objective, as precise as possible when reporting data related to our beloved. If we propose clinical alternatives, our suggestions should be grounded in solid research and clear references rather than guided solely by emotion or hope. Day-to-day patient data lives with us, while the clinical knowledge and experience reside with the medical team. So to truly maximize the patient quality of lives, these two worlds must work in perfect, coordinated harmony. Thank you.
Thank you very much. And Rachel, did you have your hand up previously? Oh, okay. So Desiree?
I was just clapping.
Oh, okay.
Thank you.
No, I think those are, those are points that, of course, are very important. I don't know whether Mark has any comments about that as well. I think some of what people are saying is unfortunately probably not limited to Norse fires, but applies to the entire ICU medical system itself. And I apologize for that, but it's things that we all need to work on. But I think especially the points that the family members make, that they are the ones, especially perhaps in the chronic phase, which they can comment on, but the acute phase is probably a phase in which at first you're overwhelmed and not I don't not understanding is the wrong word, but it's like there's not as many choices in the acute phase. We talk about options for treatment, and options for treatment in some ways deal or are dependent on how sick and how immobilized you are. I don't mean to say that people don't have options, but in the ICU particularly, there's more things that need to be done like immediately. In the chronic phase, though, right, you're the ones that are, really the caregivers and the eyes for us, but also the ones that are dealing with all the issues of the patients. They're getting them to all their appointments, dealing with the medical system, dealing with all the prescriptions, dealing with this, dealing with that. I mean, it's a very frustrating system to begin with, even for people that are relatively healthy but need certain things. I can't imagine what it's really like if you're dealing with pharmacies, insurance companies, trying to get a call back from a doctor. One of my recent friends said that they can't get a response from their doctor's office, so now they use ChatGTP to ask questions about medications. So we have a system that we need work on.
Yeah, I'll comment too, Jim. I agree with your comments. Like your center, ours is one. We're large, we're well resourced, we have experience with these disorders, but we still get it wrong, and it's not fair to families. And I'd say for the long-term phase, having the family know there's at least somebody they can contact amidst all the many services their child needs. If there's somebody on the medical team who they trust, who they can tell about what their frustrations are, who can be an advocate for them. They may not be able to solve it, but at least there's someone who can advocate on their behalf as well.
Yes, thank you. Rachel?
Yes, I thought it was worthwhile picking up something that Debbie put in our chat. So when Sam was in hospital, which is kind of 5 years ago in the acute stage, I totally agree with everything you've said about parent and clinician communications. It's absolutely fundamental to get that right. But we were allocated a palliative care nurse relatively early on in Sam's journey. He was just 5 years old. And I think that was really, really invaluable, just picking up on the last speaker, because she actually wanted to understand how I wanted to be communicated to about fires. And how much I wanted to be involved in the care. She really kind of took the time to sit down and say, what do you want from us? And I could sit down and say to her, well, actually, I don't want to be told that Sam's critically ill every single hour of the day, or by all the different doctors that come on, because I need to know there's some hope there, because otherwise, how do I get up in the morning? So she really could convey that message back to the clinical team. And also, when we were facing the worst outcome possible, which was withdrawal of Sam's care, because we couldn't control his seizures and he had catastrophic brain damage, she was one person that I really trusted. And I think, as the other speaker said, when you're in that situation in the acute stage where you don't know who you can you trust this doctor? Can you trust this nurse? To have that one person that you can lean into and trust throughout the acute stage, but also when you're facing the worst, is invaluable. And I think the role of epilepsy nurses like Deborah can really, really, we should be really leaning into them, not only in the acute stage, but also the chronic stage, which is what our UK charity is doing now with employing the services of Deborah to support families in the chronic stage through counselling and through clinical support through Deborah. But I think it's really important.
Thank you. Dr. Muskow has his hand up. I'll.
Sorry, you'd think after years I'd figure out the audio. I'm a pediatric rheumatologist and I support neurology and ICU care in our hospital along with Jim and Dr. Fisher. I would like to thank all the parents for articulating, I think, many of the barriers we see on a day-to-day basis. And I think one I've had some families over the years with fires that have really had to remind the teams that there are so many switches of teams in the ICU and even on the floor, that as they get trust with one set of teams, they often see a new one. And depending on how long they are in the ICU or floor, they might see the same people over again, but they might not. And usually those changes are either on the weekend or Monday. And you could just see on the faces of many parents the stress build up as they know the teams are changing. We had this one set of parents who were both in finance and said, "Do we need to write our goals for the week on the door of the ICU to get on the same page?" And I think Mr. Signata mentioned, I think utilizing multidisciplinary team meetings, both for the doctors and then with the families, at least for that one family and many others, was really able to reduce the stress of switches and seeing new faces all the time to know that they're all communicating and trying to stay on the same page. And again, thank you everybody for articulating all your various stories.
Thank you very much. We have some mention in the chat of the importance of an epilepsy nurse specialist, which I would agree with 100%. The epilepsy nurse specialist can be somewhat of the mediators or the intermediaries between the epileptologist or the physicians and the families. I'm not sure that every place would have epilepsy nurse specialists available to be the intermediary. That certainly is something that institutions need to think about and work on, especially, really for the care of any patient that has a chronic problem, not just the patient with epilepsy. So I apologize for not mentioning that sooner, but a very critical piece of the care. And I think for that, Nora, did you have some words?
Yes.
Yeah.
So in a way, I think we're sort of preaching to the choir here. The people, the investigators who presented, who've commented, I think that they are the people who do believe in the value of the input of patients and families. So I appreciate that. And I hope that you are motivated to take this energy and this information and inspire your colleagues to share what you see and what you have done. So it isn't just you who are communicating so clearly with your patients and families, but also the other teams. I wanted to point out something about the biomarker research that presented by Orly Hannon, Jenna Yu, and Danielle DeCampo. That research depends on biosamples. But as Desiree Cassis points out, the very idea of donating biosamples of their children can be upsetting to families. And we must take the time to explain to families the importance of biosamples and patient data to understand NORSE. And it's important to develop better treatments in both the acute and the chronic phases. And we have to hold these discussions aimed at what's in it for them to engage in research that might be emotionally draining. And recognize that until now, research has not delivered much to benefit most patients. Mark Wainwright points out the importance of doctors being humble in communication and being open to input from others. And some families have pointed out that sometimes the doctors have not listened or discounted their observations. And one way to address this imbalanced flow of communication is to adopt a team concept, as Dr. Shabana Ali pointed out, starting in the ICU. Doctors and families are one team fighting for the patient. Each team member has a different role and skills. Some take the lead in the acute phase and others in the chronic phase. They would share knowledge, respect, listen to each other and work together. I think the aim of today's symposium was to have different people weigh in on the line between acute and the chronic phase of NORSE and the implications for treatment, and the people who live with those consequences and hold untapped insights. And I hope that many of you see the value, as I'm sure you do, and encourage others to see this value on display again on day 2, symposium on the de-escalation of therapy in NORSE, this Thursday at 11 a.m. Eastern Time. Thanks, Jim.
Thank you very much. Thank you for everyone that participating, but especially thanks to the families that, gave us their viewpoint on what was happening. I know that it is very difficult for people to sometimes come forward and speak about these things in a public way, but I think it does benefit the group and the patients. And we hope that moving forward, we're going to use a lot of this information, as I said, to come up with what we would call a roadmap and disseminate it so that both providers and families can sort of get an idea about what to expect in the future. Because I think in some ways as well with any disease, but especially epilepsy, managing expectations is very, very important. So we hope to be doing that. That was one of the purposes of the symposium for today. So again, I want to thank everybody who participated. I think the speakers did a great job in finishing within the time frame that we gave them. I know it is sometimes difficult to ask someone to speak for 5 minutes and then have 1 minute of questions, but we wanted to be sure that we got a lot of this information across. We're really passionate believers about the use of the research to improve the patients, to improve their care, but also to improve what the families go through, and to perhaps even focus, I don't want to say more on the families than on the patients, but I think it's an area that we've not done a good job in. I worked on something recently and I made a comment and said, despite what we consider to be the heroic measures that we've done to help patients, we're not yet meeting the needs of their families. And we apologize for that, but we hope to do more moving forward. So again, I wanted to thank everybody for participating. Thank you for coming to this. And I'm really looking forward to Thursday, because I think for Thursday, we're going to deal a lot with not just the phases, but how we deal with the escalation, how we deal with the de-escalation, and finally, to really focus on the quality of life, because in a sense, the quality of life is really the important thing that we need to focus on for the future. And we need to do a good job in getting families ready for that and for the road ahead, especially in the setting of them being the primary people responsible for the patient's care and for all the different management things. And we thank them very much for that. So thank you very much.